you need to identify all the different impairments they have before, during, and after, because what we heard earlier with our two presenters, there's so many survivors now. And with all these survivors, they become a chronic pain patient with cancer in remission history, with cancer that is no evidence of disease, but now they have toxic chemotherapy-induced painful neuropathy that you have to deal with, post-thoracotomy pain syndrome, post-breast mastectomy syndrome, which is very debilitating. So when you think about intrathecal delivery and you think of long-term intrathecal delivery, because we have so many survivors now, these survivors still live a life. And sometimes you start intrathecal drug delivery and you think, oh my gosh, this is a failure. In actuality, you chose correctly, your selection was appropriate at the time of implant and at time of initiation of therapy, but then life goes on. Disease might get worse, so you go back and forth deciding whether or not to change intrathecal drugs, or you decide, oh, disease is no longer there, and you have no more evidence of disease, but you got in a car wreck. So on top of your cancer-related pain, you now have chronic pain from a traumatic injury. So all drug delivery is intrathecally, if you're putting it for long-term with a pump, is a delivery system. It's up to you, the physician, the artful physician, to learn about your patient and understand what to use and what to not use and change in your delivery device. So again, intrathecal drug therapy could be very successful. We want it this way, but a lot of times it's a lot of ups and downs, and that's what sometimes scares people away. So I'm going to talk about in cancer what we expect. So what we know in 2007, Annals of Oncology published this, and I still use this because this is the newest data that we have in 2007. Patients have pain after curative treatment. A third of our patients have pain. Undergoing cancer treatment, about 60% of our patients will have pain. Some type of pain, either tumor burden or treatment burden. Advanced metastatic and terminal, more than 60% of these patients will have pain. That's where a lot of these different interventional techniques really take a very priority role in these patients. And when you look at all patients that have cancer, about 50% of them will have pain. So you have to ask, you have to train your oncologist to ask what type of pain you have. And not only the visual analog scale, what type of pain is impairing your daily activities, your function, your dressing yourself, your family life, your spirituality, what type of pain is this, can we help you? So I train a lot of interventional fellows, and before I have them put a needle in somebody, put an implant in somebody, they have to tell me and identify me what kind of pain they think they have that we're treating, because certain things respond better to nociceptive pain than neuropathic pain. You do different treatments. In nociceptive pain, this is visceral pain, which is considered nociceptive from tumor in the liver, metastatic disease there. The capsule distends, the patient perceives pain. This is metastatic bone disease all over the body. So all these regional techniques with nerve ablations and nerve blocks, this is not going to help this patient. So we need to think of other ways, not just systemic pharmacotherapy, that might be beneficial for this patient. Fortunately, there's drugs coming out systemically that will help bone pain that's under clinical trial at this time. Different lecture. This is another example of nociceptive pain, and our surgeons, maybe some in the room, did this beautiful piece of artwork for that right hip. What's interesting for this patient is that this right hip was not the patient's pain. What was the patient's pain was the left sacroiliac joint. Because if you can imagine, the gait changes for this patient because of that artwork on the right obviously causes a lot of strain on the left. So my fellows need to tell me this person is probably not good for a pump, might be well with rehabilitation therapies and a sacroiliac joint injection, or maybe even an ablation. So neuropathic pain, this is a very painful problem. This is tumor along the nerve roots as it's exiting the spine. You get the neuropathic pain. That's a large tumor over the brachial plexus. This is a horrible problem as well. And many of you guys see this also for the immunodepressed, is the postherpetic neuralgia. And in my world, in my research, we are looking at chemotherapy-induced neuropathies. This is from Velcade for the treatment of multiple myeloma. They get better with regards to their disease, but the treatments for their disease causes very debilitating neuropathies of their fingers and toes. So different treatment strategies for nociceptive and also neuropathic pain. So this is supposed to be a video, but there's no video there because this turned into PowerPoint. So I want to talk about interventional therapies because obviously cancer pain is very difficult to treat in its presentation. Here's a bunch of the different things that we provide in our service at MD Anderson. And what I was told to talk about today was spinal infusions, implanted and external. I'll talk really about implanted today because that's a lot of my practice. Tomorrow I'll talk about tumor ablations in the spine as well as vertebroplasty and kyphoplasty if you're interested in that. So I like talking about a person because my patients are people with feelings. And Angela is one of my patients that I label chronic cancer pain. She had a presacral ganglion neuroblastoma when she was 3. This patient of mine has had pain since she was 3. She's now 23 years old, and I've been following her for the last 7 years. She had radiation-induced osteosarcoma after the treatment for her ganglioneuroblastoma, multiple pelvic surgeries, girdle stone procedure, cauda equina, she's obese, wheelchair-dependent, opioid-tolerant, and chemical coping was a problem, and I sent her to psychotherapy. She had ongoing psychotherapy, systemic pharmacotherapies. So we had a discussion, is this person appropriate for intrathecal therapy? She's young. And I don't want her to go down that opioid road, especially in the United States where we have a very bad epidemic. So what do we know? In 2002, Tom Smith and our colleagues published this paper. It's the Sentinel paper in intrathecal therapy that you all must be familiar with. It was a prospective multi-center trial. And what I want to have you take home with this is that intrathecal therapy was effective for pain control. But when you look at that compared to the WHO ladder, which is validated, which works, we know it does, what the nice part about intrathecal therapy is that in this paper what they found that it reduced a lot of unwanted side effects from systemic opioid therapy, including fatigue, confusion, depressed level of consciousness, personality, behavioral, constipation, vomiting, pruritus, memory loss, anorexia, dehydration, weight loss. Tended towards significance, but the ones in the bottom box didn't show significance compared to the top box. What's very interesting about this paper too, which was not their primary outcome, so it was critiqued a lot, is that there was some benefit with regards to survivorship. If you have intrathecal therapy compared to systemic opioid therapy, these patients in the long term didn't make statistical significance. Maybe it was not powered correctly, but it showed a trend towards improved survivorship for the intrathecal therapy group. So this is what we know. This is old. This is what we still look at. This is what I've tried to, my consortium have tried to say, let's repeat the study and see what, with the medications that we have now, can we reproduce or make this study even more pronounced? But we don't have a study. So moving forward, what we find is that we borrow a lot of studies and information from our cancer colleagues. What we know about cancer was in the 1940s to 1960s, we used a lot of chemotherapeutic agents that were mustard agents and antifolate. And the problem with that is that it killed all cells that were mitotic. And the problem with that, it's a dirty drug, it causes a lot of side effect and toxicities, but when you fast forward time in the world of oncology, in the 2000s, things became more targeted. So now we have PARP inhibitors, which are more targeted to the cancer. So when you look at the cancer therapies, and then now you look at pain, this is what we're going towards also. Targeted therapies for pain. So that's the trend. Morphine was something we did intrathecally a long time ago. It was the first drug given intrathecally, and it hits many different targets. And what we're now looking at are newer agents. Over the last, not even a decade yet, ziconotide came out, and that's a conopeptide. And what's interesting with that is that it targets the N-type calcium channel. And I'll talk about that a little bit later, but I just wanted to present a trend that even in pain, like oncology, we are getting more targeted in our therapies. So in 2012, and this is a paper that is available for download. It's the Polyanalgesic Consensus Panel, International Panel, and this is going under more revision for the newer version. But in 2012, there was expert consensus and guidelines based on available literature in 2011 about what's first line, second line, third line in use for intrathecal therapies. This is for all pain, not just cancer pain. They have one for neuropathic pain and one for nociceptive pain. And I know you can't read that, but I'd be happy to share these slides with you. So moving forward, as we look towards the future, what are we expecting as we're getting more and more targeted? We look at receptors. We look at targeting receptors with different types of agents. Unfortunately, some of these agents are not systemic. They're only intrathecal. We know about morphine. I talked a little bit about ziconotide. I'm doing research on ziconotide. I'll share a little bit of that. And then we know about gabapentin. If you know about the gabapentin intrathecal trial in the United States, I'll throw a few slides on that. And something very new is resifiterotoxin, which is, we're going to start recruiting patients at my center for that. So a quick thing on gabapentin, since I'm running out of time. Intrathecal gabapentin was trialed. You think for neuropathic pain, you take it systemically, it works very nicely, and you have some side effects. But unfortunately, when it was used intrathecally during this trial, it didn't work at all. So unfortunately, it's not available at all for intrathecal delivery because it did not work. I'm looking at ziconotide and the use in cancer pain, because all the studies, none have been really focused in cancer pain. I presented this with one of my colleagues at NANS a few years ago, and what we found was that a single shot of ziconotide reduced pain quite significantly in a lot of our patients with cancer. What we found also after the single shot, weeks after with intrathecal continuous delivery, what we found was that at about 6 weeks after follow-up of initiation of intrathecal delivery, we found that the ziconotide provided good pain reduction that reached statistical significance. So in summary, with ziconotide as the newer agent for intrathecal delivery, we found that by 6 weeks of titration, at least 50% of patients with ziconotide infusion reach a stable dose. After 6 weeks, intrathecal titration of ziconotide, patients reported at least a third reduction in average daily pain. And we're writing a manuscript for that now. So what's very, very new, what's still phase 1-2 clinical trials, and we're one of the sites that are recruiting for these patients, is resifiterotoxin for refractory cancer pain. And this is related to your capsaicin, but it comes from a cactus. We know that TRPV1 receptors are expressed on A delta and C fibers. These TRPV receptors are hyperactive in disease states with severe pain. We know this, so we need to target this. So RTX, or resifiterotoxin, selectively binds to the nerves of TRPV1. And when it binds to these nerves, it destroys the alpha, delta, and C fibers. And this would